this is just a quick case that we're going to be showing for wingspan for intracranial balloon angioplasty and stenting. This is a 73-year-old woman. History of coronary artery disease, hypertension, hyperlipidemia, had a left hemispheric watershed ischemic stroke, and she was found to have severe stenosis of the petrous segment of the left ICA. We use NOVA, quantitative MRA analysis, to assist in the decision-making for these patients. And I'm going to show more of that data now. The equipment that we used, she was very tortuous anatomy, so we used a Neuromax a VTEC catheter, required an intermediate catheter, a 5 French in Navion 58, and by also needed an Excelsior XC27 microcatheter with a couple of micro wires, depending on where we were in the curvature of the anatomy, to be able to have enough support to advance the catheter, to have a safe position, and use a gateway and a wingspan. So this is the case. These are FLAIR images on her MRI showing the watershed infarctions. This MRA showing the severe stenosis of the petrous segment. You don't see an A1 segment of the ACA. And here you see the NOVA flow metrics that shows a decreased flow in the left ICA. We're using a lot of NOVA to determine if someone has decreased flow despite not failing medical therapy initially, if they have a territory at risk. You can see here the tortuous anatomy, how we're navigating the catheter. We have a Neuromax in the common that we're advancing, and you see how we're advancing the Navion. It was a challenge to get there, but we were able to get to a safe position and a very stable position of the catheter. You see how it's advancing in the distal cervical segment of the ICA in the lateral view. So now we have our working position, and we're going to start prepping the balloon and the stent. For the balloon, we use, you see in the measurements here, it's difficult to see from there, but we're going to use approximately 80% of the normal diameter of the vessel below and above the stenosis for the balloon. And you see we use an insufflator and flushing the stent and the hypotube. Need to be very careful with that proximal end of the pusher, or you can bend it and then have trouble at the time of deploying the stent. Now we're using the Transcend microwire, and already with the balloon, the gateway balloon, we're getting there to the area of severe stenosis. And now we're performing the angioplasty. We're looking under roadmap as well as native images that we're not showing here, but we're looking for the expansion of the balloon. We use 50% contrast for visibility of the balloon. And you're going to see now we deflate the balloon, remove the balloon, do an angiogram, and it does look already much better, especially in that B plane. And now we're going to proceed with the stent. And as I mentioned before, we are using a lot of the flow information from the NOVA to determine if someone should be a candidate for this type of procedures. Obviously, the ones that fail a maximum medical therapy are obvious candidates, but sometimes it's a first event, and we know that the patient is at risk either because they have an isolated hemisphere or they don't have good collateral circulation, and with low flow in the NOVA, and those we definitely consider for the stenting. We have a lot of this information for the posterior circulation demonstrated in the Veritas trials, but we're also using it in the anterior circulation. The stent is deployed. This is the angiogram immediately post-stent. Now you can see an A1, an ACA that you couldn't see initially. It's hypoplastic, but it's present. And we do a post-stenting NOVA that shows improvement in the flow in the left ICA, left MCA, left ACA, and even the left posterior communicating artery. And this is how we're going to be following the patient from now on without having to do repeat angiograms, just the NOVA follow-up MRA. Thanks a lot for your attention.